Thank you for viewing the Kentucky Regional Extension Center's new Mandatory Ambulatory Specialty Model Overview. In early 2026, the Center for Medicaid and Medicare Services, or CMS, announced a new ambulatory specialty model to gauge individual clinician-level performance around high-cost chronic conditions. This mandatory dual-sided risk model was designed to increase specialty provider accountability through the co-management of Medicare beneficiaries' care. Here are some quick facts about this model and how it could impact your practice. This is a mandatory dual-sided risk model. ASM participants will see escalating risk from 9 to 12% over the life of the model. The model begins on January 1st, 2027 and runs through December 31st, 2031 for a total of 5 model years. ASM participants are assessed at the individual provider level, not the tax ID level, and participation is limited to certain clinician types. Selected clinicians will participate in one of 2 cohorts, low back pain or heart failure. The framework of this model is based on a composite of the Quality Payment Program's MVP and APP tracks with components of advanced APMs. Mandatory selection of this model may impact your individual clinical level reporting requirements for the Quality Payment Program. Mandatory participation is based on several factors. ASM participants must meet the following criteria: bill claims under the Medicare Physician Fee Schedule, be identified in the 10 NPI combination as a selected medical specialty type based on the most frequently assigned specialty code indicated on Part B claims, included specialty codes for the heart failure cohort or cardiology, for the low back pain cohort, anesthesiology, orthopedics, orthopedic surgery, interventional pain management, physical medicine and rehabilitation, and neurosurgery. You must meet the episode-based cost measure episode volume threshold, which is 20 episodes, that are applicable to either the low back pain or the heart failure cohorts. And finally, you must be located in one of the identified mandatory geographic areas. In January 2026, CMS announced the mandatory Kentucky Core-Based Statistical Areas, or CBSAs, that are applicable to this model. The Cincinnati Northern Kentucky area, Glasgow, Louisville Metro, Lexington Fayette, Paducah, Pikeville, and the Richmond Berea area. At least 40% of applicable specialists will be required to participate within each CBSA. CMS also released the initial participant list and expects to release the final list for 2027 participation in mid-summer of 2026. Now let's talk a little bit about the cohorts. The heart failure cohort quality performance category is made up of 4 clinical quality measures that can be reported as ECQMs or MIPS-CQMs, plus an additional administrative claims-based measure. The cost category is scored based on the individual provider-level performance for the heart failure episode-based cost measure, or what we call an EBCM. Episode windows are between 365 and 729 days in duration. Episodes are initiated by a beneficiary receiving 2 related services within 180 days. The low back pain cohort's quality performance category also requires the submission of 4 clinical quality measures that are specific to the cohort and will include 1 administrative claims measure that will be released in subsequent rulemaking. The cost category episode duration is somewhat shorter in duration as compared to its heart failure counterpart. Episodes can last from 120 to 484 days. It does have a shorter 60-day trigger window. Each cohort has quality and cost equally weighted at 50%. Improvement activities and promoting interoperability, key components of the Quality Payment Program, play a role in ASM as well. However, there are several important differences. Providers are expected to excel in both categories with this program. In fact, anything less than perfect will bring down your overall performance score for the program. They carry no final score weighting, but can deduct points for this score and impact your access to the ASM incentive pool. Final scoring for this model is also different than what we've seen with the MIPS program. There is not a threshold to avoid penalty, but a moving target year to year. You'll be assigned a score based on your overall performance, and scores above the cohort's median performance for that year will receive a positive incentives, and scores below the median will lose a percentage of Part B revenue through future claims adjustment. Let's take a couple minutes to talk about what this model means for you if you're selected as a mandatory participant. So some initial considerations are really around your reporting needs, making sure and taking a look at your EHR, or look if you have a registry or if you need to have a registry in order to meet the quality performance category requirements for either of these cohorts. We also see that there's a need for increased staff for care coordination activities. Care coordination activities is a through line throughout this particular model. We also see that there's specialty provider involvement in health-related needs screenings. That's one of the improvement activities that are mandatory for this particular model. This is something that is new for a lot of specialty clinicians. This is something that has maybe sat outside of their wheelhouse, and they've depended upon their primary care counterparts to be able to close those gaps and to identify those patients with health-related social needs. Additionally, we see collaborative care arrangements. Those must be made as a part of an additional improvement activity. And so linking specialists with those primary care providers within their beneficiary population to establish collaborative care arrangements. Again, this is a new component that many clinicians may not be experienced or well-versed in. And then finally, we're seeing that there are quite a few non-MIPS eligible clinicians that have been moved into this model. So they're very risk naive. They're going from a fee for volume or fee for service background to moving fully into a dual-sided risk model. They're skipping that fee for performance that we've seen and gotten used to with the quality payment program and the MIPS track specifically. So we have a couple key takeaways that I would like to talk about as well too. So this model, again, signals CMS's move for specialist integration. They really want to bring in that specialty care for accountability when it comes to delivering care and services and lowering the cost of care for their beneficiaries. We also see a move to provider level accountability. CMS has signaled this for a long time. They really want to have that individual provider level detail around performance for beneficiary engagement and for access to choice and to really drive competition. CMS has also indicated with this program that your ASM score is going to override any sort of MIPS or qualifying participant in an ACO, any sort of designations related to those programs. Your ASM performance and your score that is earned will trump a MIPS score or an ACO score at that individual provider level. And then finally, there are significant concerns with the reporting burden for practices and individual clinicians. There are lots of parts and pieces with the improvement activities, with promoting interoperability. There is no flexibility. There are no small practice exceptions for the promoting interoperability performance category with this program. So this is new, and this is potentially very impactful for our small practices who have depended upon some of those flexibilities in the past. Questions about how you or your practice can be impacted by this new mandatory payment model? Contact your experts at the Kentucky Regional Extension Center for all of your ASM questions. Reach out today at 859-323-3090. Visit us at KentuckyREC.com or send us an email at KentuckyREC@uky.edu. Thank you.